welcome back to this afternoon's session. Our next panel debate is called Do We Need to Redefine the Role and Priorities of EU Health Policies? Now, back joining us again, we have John from the European Commission, John Ryan, who you heard from this morning. Then let me start from the very far end. We have Neil Betteridge, who is an independent health consultant, but more importantly, a patient advocate to NHS England as well. Next to him, we have Marianne Chapman from the European Trade Union Institute, and she is head of unit Health, Safety and Working Conditions. We have our MEP, Manuel Pizarro, who is also a physician and is also on the Employment and Social Affairs Committee in the European Parliament. And then, last but not least, we have Fiona Godfrey, Secretary-General of the European Public Health Alliance. Thank you all very much. I'm going to start off with that very broad general question to all of you, just so we can get a sense of where you intersect with the idea and the topic of the panel. Fiona, let me start with you. So, do we need to redefine the role and priorities of EU health policies, and why, from your perspective, do we or don't we?
Yeah, we absolutely do. The last 5 years have been pretty deathly, I think. No offence to John here, who in the Commission services and his team have done a great job, and to the extent that they're allowed to. But we really need some new political vision and some new political thinking in the new Commission and the new Parliament, and I hope we'll get that.
Okay, well, in that case, Manuel, I think you're the obvious next choice to pick up. New thinking.
Well, thank you very much. I think that we have a good political and social commitment to do that, to improve the intervention of European institutions in the health sector. Because if we politicians say, and we are always saying that we need to create proximity between European citizens and the European Union, of course that we must address the main concerns of people. And mainly for good reasons, health is one of the main concerns of the European citizens, because we are living more, and it creates new problems, and because we all want to live better, healthier. So I think that we need to improve the political action of the European Union in the health sector, and there is no legal reason to don't do that. Yes, it's true that there is a shared responsibility between the European Union and the member states in the health policies, and of course that in the health issues and health systems, the subsidiarity principle applies, of course. But there is a large space in the treaty and in several other areas of work of the European Union to improve this intervention. Perhaps I can, however, give an optimistic note. And for me, it's a pleasure to be here in that meeting of the EULAR, because I think that we are in a very good moment to speak about health in European policies. If you have the opportunity, perhaps you have already done that, to read the mission letter that was given for the President-elect to the Commissioner designated, Mrs. Stella Kyriakides. This is a very open, a very good mission letter. I'm very enthusiastic about that, because I think that that mission letter opens a huge space of debate and of intervention for the European institutions in the health policy, because I completely agree with what Fiona said. Mainly, we need political vision.
Marianne, then, same question to you, but perhaps touch on one of the issues there that Manuel raised, which is the subsidiarity principle, the idea that member state competencies are a little bit difficult to align.
Thank you. First of all, I think I want to thank the organizers of this conference for the kind invitation. It's the first time for me, and maybe also for our institute, that we participate in a conference like this, which is very much patient-based. And I really want to stress the fact that the concept of EULAR really appeals to me, the patient-based vision, and the cooperation with the scientists and health professionals. And I had a visit of a few EULAR representatives half a year ago, and we had a really good conversation, and we spoke about exactly the topic of this conference, and that is work. And the participation of patients in work. My primary focus is work, and which doesn't mean that my primary focus is not health. It's occupational health, so health related to work. And I think, as said before, we often work in silos. It's the health perspective, it's the work perspective that is separate. So that's why I'm really happy to be here. To reflect on the question, do we need a new health policy? So I am going to focus on the occupational health side of that. And yes, there we certainly have wishes at the European level. And in the occupational health and safety regulation, the European Union has always, European legislation has been very much on the forefront. We do have a very good basic framework directive on occupational health and safety that sets, that formulates the basic principle of prevention of health, of bad health. There are 22 so-called daughter directives also in the field. What I want to say on the topic of today, there are very good basic principles formulated in the framework directive about prevention. If we speak about work, it's all about prevention of occupational diseases, and RMDs can be an occupational disease as well. So where I want to put the focus on today is work as a causal factor of RMDs, a causal factor where you have possibilities to make gains by way of prevention. Prevention is the basic principle in the framework directive, as said, but it's too global. There are at member state level, to come to your question, at member state level, there are hardly any regulations targeted at the prevention of MSDs, or as you mentioned, RMDs. Hardly any regulation at member state level, and the performance of companies is most of the time low on this topic. Whereas we have 25% of the workers' population that has to deal with musculoskeletal disorders. So there is a lot to gain, and I think there's a lot to improve. Not only at national level, but indeed also at European level, and this being also the traditional way of regulating the topic of occupational health and safety. Thank you.
Thank you. To you then, Neil, the patient's perspective, and do we need to redefine the roles of EU health policies? We've talked about priorities, but what about the roles?
I think it's difficult and perhaps impossible to determine whether existing priorities are the right ones or the wrong ones unless we know what criteria we're using to judge them. So I think it's important to understand how priorities get set and what factors are taken into account, because a priority it's a decision. It's this and it's not that. It's an apple but not an orange. So a priority is set through a number of subjective, even if they're evidence-based components, they're still quite subjective because they're ones that are chosen for inclusion. So the social factors and determinants and political determinants that go into setting priorities are perhaps the thing we should be assessing here. Because if we generate some consensus around those conditions, those criteria, those determinants, it might be easier to see what a good priority looks like. So let me move from this rather abstract introduction there to something slightly more concrete. To do this, we need to take into account, I think, the decision-making process. And it's impossible to not take some kind of account of where the European institutions are in 2019. And Jennifer, as you said when you premised one of your questions to John this morning, some people out there in the real world do feel that Brussels and the decision-making powers are or can be a little bit remote, a little bit distant. It seems a little bit opaque. It doesn't mean it is. It doesn't mean those things are true, but that's how it can seem to some people. So sometimes the EU institutions are criticised on that basis. Sometimes the EU institutions are criticised for being too interfering and daring to tell member states what they should be doing. So it's a very tricky position to be in at the moment. You're sort of damned if you do and damned if you don't. So one could, or the EU could, choose to adopt one of those positions at the edges, but more likely in the next 5 years, we're going to see some carefully positioned policies which will seek to strike some sort of balance where health policy and related policies, and that's a really important point I'd like to come back to later, the intersection between policies, where those policies need to deliver value and they need to be seen to be delivering value too. So I would say, top of my list, and on behalf of EULAR in this capacity, we want to see outcome-focused priorities. We want to see things which make a difference in the real world, whether that is keeping somebody in their job, keeping them, as Peter so eloquently described earlier, improving and maintaining well-being, maintaining productivity so that the person is a taxpayer and not a disability benefit claimant, or whether that outcome is at the clinical individual level. Because a good patient outcome in a clinical setting means that the drug or the therapy or the support is working. Even if it's expensive, that makes it good value, because that person is then supported to be independent, productive, it improves well-being and decreases their demand on other health and social care services. So I can get more specific and more concrete later. I don't want to overspeak now, but I think we should be looking at things which deliver the maximum impact to individuals, and that we then get the payback out of that, the return on investment that several of our speakers have highlighted already.
Okay, John, I asked you about priorities this morning, so I won't labour that point. But let's pick up on what Neil said there. I see you scribbling away in reaction to what people are saying. What about the difficulty of the Commission daring to tell member states what to do, as he put it?
Mm-hmm. So I wanted to just make a few remarks. First of all, I think it's a mistake to focus entirely on health policy, because health policy is limited by what we have in the European Treaty. And essentially, in relation to public health policy, it's limited to the coordination of member states' positions in respect of the grand, or the big health scourges, I think they call it in the treaty. So in other words, it's intended to bring together the member states' reactions and responses to major health threats. And there are some concrete examples quoted in the treaty. Then you have areas where legislation is allowed, and we heard about health and safety earlier on, which is a very strong area of EU legislation from the very beginning, from the word go. It was one of the original areas of work of the European Commission and of the member states. But then you have, which I think is a much more undeveloped field, is the study of where health can be developed in other community policies. And of course we have examples of where this has been successful and examples where it's been less successful. So I think there's a great potential for developing public health activities in the future, that's for sure. But there's also a great potential for making sure that we identify how other community policies and legislation can be mobilized to support and protect health. And this is already the case, I would say, for the legislation on workers' health and safety, but it needs to be more integrated in some of the other community policies as well. And we're not starting from scratch in terms of defining priorities, if I might just refer to that point, because we have what's in the treaty, the areas which I mentioned in the treaty where the European Union actually has a mandate to do something, because we're a treaty-based organisation, so we can't just decide in the morning we're going to do this or we're going to do that. We'd be very quickly stopped in our tracks by the legal service and also by the Council and the Parliament. So we have to respect very carefully what's in the treaty. We're not free actors, but there is a lot of possibility in the treaty to take action. But in addition to what's in the treaty, then you have the Sustainable Development Goals, which are agreed priority areas and targets which have been agreed by the Member States and by the Commission. And that's an ongoing setting of targets for the next Commission, for the next 5 years. And you mentioned the mission letter, Mr. Pizarro, you mentioned the mission letter of my commissioner, but also other commissioners. They all are phrased in the terms of the Sustainable Development Goals. So that's a political commitment of the Commission to work, to continue to work in the Sustainable Development Goals. You must also remember that all of the member states are members of the World Health Organization. And the World Health Organization has strategies on everything you could imagine. But also at the world level and at the regional level, at the European regional level, they have very fixed and very targeted interventions and plans for different diseases and different conditions and for prevention. So I think it's important that we take account of what's in the treaty, what we can legally do, what's in the Sustainable Development Goals, what the World Health Organization is recommending, what the member states want to do, because they're the ones who are running the health systems, and they also have their own economic requirements to take into account, whether the economy is blooming or not blooming, whether they have a sufficient workforce, whether they have, what are the needs on the member state level for a particular intervention. There's no use establishing some changes in the health system if it's not actually needed at the member state level. And then finally, of course, the intervention of the European Parliament, which reflects the voice of civil society, reflects the voice of stakeholders of different types. I've just come from a meeting in the European Parliament this afternoon on mental health, and it's quite clear that on an issue like mental health, the European Parliament has a very strong voice, because it can raise the flag and say this is an area where not only member states but also the Commission needs to invest. So the Commission welcomes this dialogue with the member states, but also with the Parliament and with stakeholders, and that's how we define our priorities.
Okay, well, we've talked about sort of the intersection points between health and other areas. So let's delve a little bit deep into that and take and ask where policy can work and say the intersection between health and innovation. Because we hear a lot about innovation, we hear about how big data is going to change the world and how we do everything. But where do you put in place the policies to drive that in the direction we want with regard to health? That's an open question to whoever wants to jump in and answer it.
Well, I can just begin and then...
Yes, go ahead.
Because I fully agree with what John Ryan said. We can use a lot of other areas of intervention of the European Union to deliver important policies in the health sector. For instance, we do that when in the things that have to see with the internal market, we approve some measures that can impact a lot in the health sector. For instance, the regulation on health technology assessment, it was made in the internal market pocket, but really it impacts in the care of the patient, in the care of the people. And I think that we must be very audacious with using all the possible means to answer that important question of delivering affordable care and good quality care and modern care to all patients in Europe. So I think that in the next mandate we will have an opportunity to mix the funds that are used to finance innovation in the mainly directed to the economy and to a sustainable economy in Europe. This is essential because at the end of the day we will need to have money to pay the bills. So it's important to look at the health sector not only like an area that we are going to put money, but also as an area where we can get more people to be more productive, and you have already spoken about that. And also we can develop a good economic sector based on the health sector, and that's quite important and quite urgent too.
Okay, Neil, you want to,
Yeah,
all of you want to jump in. Okay, I'm going to go to Neil next.
Me first, or?
Neil, yeah.
Yeah, okay, thank you. So I just wanted to come at that question from an RMD specific perspective, both actually on the clinical and the patient side, if I may briefly. So in my short lifetime, obviously I'm very young, I've seen incredible innovation in rheumatology. When I was a child with juvenile arthritis back in the 1960s, there were no great drugs for that sort of inflammatory arthritis. I had aspirin, and that was it. And I was eating them like sweets. There wasn't even soluble or children's aspirin. So this should be the golden age now, really, considering where we came from just 50 years ago or something. But it isn't the golden age. We've seen tremendous benefits, especially in the last 20 years with the advent of the biologic therapies, which have come about through investment in research which had the promise of innovation. And there's still plenty more in the rheumatology pipeline there to get. So that's one very concrete example, I think, that the Horizon Europe assessment should really be focusing on innovation that delivers the same level of benefit with all of that outcome I mentioned earlier. Secondly, from the patient side of things, the patient perspective, I think going forward, we have to go back to one of the other things that was cited in the missions letter, along with we haven't really had too much discussion on that today so far. Now, digital technology, of course, is not an answer. It's a tool to an answer. It's something that helps something deliver, hopefully, benefit. And I think you can't disassociate that from the increasing role of the citizen and the patient in managing their own healthcare going forward. So, as Peter said, what does holistic care really mean? Well, I guess it means optimising the benefit to the individual with the condition, in this case RMD, by getting the best out of the physiotherapy, the best out of the therapy, the best out of their access to self-management tools. And the digital promise is one where an incredible amount of digital tools to support better self-management is feasible. But it's a bit of a mess out there. Nobody really knows which ones are validated, which ones are evidence-based. It's very, very difficult. So one concrete way in which I think EU policies can support better outcomes for patients is by doing some work, and I know there's plans to do this, which is commendable, the European health data space being one. We need to make sure that we make it as easy as possible for people who care for people with RMDs and people who live with these debilitating conditions when not well treated to actually get the best out of the potential that we see before us now in the digital age.
Okay, Marion, did you take it?
Yes, I am not sure whether I understand your question quite the same as the gentleman beside me. It's because if I understood you correctly, you stress the benefits and the hope we have from innovative inventions, let's say, yeah. And I understood your question more also in a way of innovation also has another side. Innovation can also have a side, especially concerning the workers. I give an example. Ongoing automation and artificial intelligence has an impact on workers. Ongoing automation can mean that we need to work with robots more and more. We will be, as a worker, we will cooperate with robots. That means a different way of working. And then I remember the speech of the barman, Peter. It can be very tiring to work, to cooperate with robots. Why? Because it's monotonous, it's repetitive work. So innovation also has another side. And of course, it's a complete. I don't disagree with you on this. Absolutely not, because the good sides of innovations are there. But there are also innovative developments that are not good for workers, and therefore not good for RMD patients. There we need to take into account. The legal principle, the so-called precautionary principle. If we introduce innovative techniques or other innovations in the workplace, we need to take into account the risks that these innovations cause for workers. So, thank you.
Thank you. I think I was being a little bit utopian, but reined that in. Fiona.
Thanks. I think innovation is one of those words which has a different meaning to different individuals and different sectors. And certainly I'm going to add another perspective here. So first of all, just to link up with what's just been said, I think EFA and some of its members do have some concerns about the future of the innovation principle, certainly in the research agenda, and what it may or may not be used to do, and some philosophies and values that it might be used to drive in the next Horizon Europe research programme. We're particularly concerned that it could be used as a measure to try and get round and evade the precautionary principle. There's no real definition of what innovation is or the innovation principle is at the moment, whereas the precautionary principle is enshrined in the treaties and we know what it means and it has delivered some good results. So we don't necessarily see a full-on drive to innovation as a 100% good thing. We think that there has to be some thinking and that there has to be quite a much wider discussion, not just amongst patients and researchers, but amongst civil society in general about what it is and where it's coming from, because some of the sectors, let's say, that are driving it or promoting it have form in promoting other principles and values which have not always originated in the best place or for the best reasons. And just like to say, from a more general public health perspective, I think what would be genuinely innovative is if we were actually to act on the evidence of what works to prevent disease and to promote good health. You know, we're talking about digitalisation of society, we're talking about AI, we're talking about big data, but we're still nowhere near where we should be in terms of promoting the prevention, the mass population level prevention measures that we know work, the WHO best buys. We're not properly addressing the commercial determinants of health. You know, for me, it would be really innovative if we were to actually take on the vested interests, such as big food, big alcohol, and still even big tobacco, after all that we have done so far to get around them. So that would be innovative. Let's just do what works, and let's get some legislation in there. And let's, going back to John's earlier remark, let's be creative again with EU legal bases. We did that in the 1990s. We got the fantastic health and safety at work legislation. We got some great public health tobacco control legislation. We got an international treaty on tobacco control. So let's get innovative that way. Let's also adopt a rights-based approach to health. And let's just have let's walk the walk rather than just talking the talk on public health policies and public health measures. We hear a lot from politicians, from the Parliament, from the Commission. They told us in the European Parliament elections this year that the individual and citizens had to be put back at the centre of the European project. So let's do that. Using public health, let's link up with the Green New Deal that is being proposed. Let's think very, very carefully and profoundly about how everything is linked. You know, food systems, we very much welcome the Farm to Fork initiative. In the mission letter to the new Health Commissioner designate, we need to talk about the role of climate change in health and what it's going to do to public health in Europe and for our citizens. And we just need to create a health-enabling environment, and that would be innovative.
Before I come to you, John, let me pick up on one or two things, Fiona, just specific, because this is something I hear in quite a few of the conferences I do, around data protection, and of course health data is sensitive personal data. And you mentioned the possibilities of big data. What do you think about the idea of having a data donor card, whereby you can voluntarily, you know, that gets us around some of the new general data protection laws?
I think that's interesting. I was taking part in the Research and Innovation Days a couple of weeks ago, and we had a workshop on prevention, and I was moderating it. It was in the context of the Cancer Mission. And we had a researcher there who's working on a pilot project, which is funded by DG Connect, in fact. And she said, I want all of your data because we can work on prevention at the single cell level. If you just give us all of your data, we can get there. And we won't have to we won't have to worry about doing sugar taxes or any of that. We'll be able to sort it out. And those of us who come from the population level prevention sector were like, oh, whoa. And interestingly enough, there were a couple of member state officials in that working group, and they were going, oh, no, we are not giving you all of our data. Hold on. And she said, yeah, but we can do this and we could do that if you just give us your data, and GDPR is a terrible idea and it's stopping us doing everything. What do I think about the idea? I think that depends to some extent whether you are a patient or whether you're talking about it as a citizen. If I'm talking about that as EFA and the EFA Sec General, I'd think, yeah, maybe, but I think it needs some thought. If I'm talking about that from the perspective of someone who comes from a family in which a particularly nasty, rare disease is endemic, for which we don't even know what causes it, and for which there is no known cure and very few treatments, I would probably have a different perspective. I would want my data to be, spread far and wide. But as EFA Sec Gen, I think I would call for and a lawyer by training, I think I would call for some thinking.
Okay, John, I said I would come back to you. Do you want to rewind? We've covered an awful lot of ground since I asked the question.
Yeah, so I think innovation can be very beneficial for public health. And I think that's the first thing I'd like to say. But of course, we have to be selective in the take-up of this innovation. I can give you two examples. The first is a plan of the new commission, the incoming commission, to develop a European health data space. And I think this is an idea which has a lot of potential. Because if you think on an individual level in the room here, how your health records are actually kept. There are some countries which are very developed, of course, particularly those countries which have unique identifier numbers for citizens across society, so there's no problem about identifying who you are. But there are quite a number of countries where the health records are fragmented in different settings. So your dental records will be somewhere, and then your screening will be somewhere else, and your annual checkup in the office will be somewhere else. So this causes a lot of difficulties in actually having a good overview of a person's overall health, because different aspects are stored in different places. And this leads to all sorts of problems. For example, when somebody is hospitalized, how do the hospital authorities have access to the history of the patient in a complete way? So the idea of developing an electronic health record, because of course we're gone beyond now having paper health records, so naturally it's an electronic health record, poses a lot of issues. It poses issues of classification, it poses issues of access and of ownership of data. Because of course if the insurance companies, for instance, have the same access as the doctors, then there's a number of moral questions which are posed, or if your family has access, there may be other issues. So we have to tread very carefully here, but I think in principle the idea is to have a more unified approach to patient data through an electronic health record. Another example I wanted to give you is in the area of medical imaging. And curiously, the developments in artificial intelligence are allowing us now to develop tools to scan medical images of different types. It could be cancer, but it also could be other types of medical images electronically, in order that the analysis of these images is done almost automatically based on huge data sets. And we're working with our colleagues in DG Connect of the Commission at the moment to develop an artificial intelligence concept for medical imaging, which will be particularly relevant, I would say, for issues like cancer, where you have a large proportion of interpretation problems for certain types of cancer screening. So we're hoping that through mobilizing artificial intelligence in specific areas, we'll also be able to drive innovation and improvement. On the question of Horizon Europe, Horizon Europe has as its basis innovation, because otherwise there wouldn't be a research program. But clearly one of the problems with the existing research program, which we're trying to address for the future, is the issue of the implementation of results. Because it's very nice if you invest 20 million euros or 30 million euros in a project, but then it's much more interesting if you can see that the results have been implemented somewhere. And that's why we're actually trying to link the member states more closely in the setting of the priorities of the research program and in the following up of the outcomes. And a specific example I would give you is in relation to innovation in pharmaceutical products. You know what, we have what we call the Innovative Medicines Initiative, which is part of the research program. And this is intended with the pharmaceutical industry to develop new and innovative therapies. The problem with this, of course, is not the development of the new therapies, but what happens once they're available. In other words, which member states will be in a position to actually implement the treatments or to roll out those treatments. So the vision of the pipeline is very important. If you just receive the outputs of the pipeline from the extreme end, if you like, if you don't see where the products are in the pipeline, then it's very difficult to plan on the member state level the implementation. You suddenly find yourself with a new vaccine. You suddenly find yourself with a new cancer treatment. But the question is then, how do you pay for it? And then you have all the inequalities which are caused by some countries accepting the reimbursement and some countries not accepting the reimbursement. So one of the important points, I think, is to involve the payers and the member states at an earlier stage, so that you don't end up with new treatments which increase inequalities between patients rather than decreasing inequalities between patients. So those are some of the aspects of innovation which we think are important. While encouraging innovation, you've got to be careful that they don't increase inequalities between patients in a health system. And I can only acknowledge what Fiona said about doing what's shown to be effective. We have put in place in the Commission a system for identifying best practices and interventions which are evaluated and have shown to have impact, and then paying for those using community funds. So we think innovating in health systems, also in prevention, is important. Thank you.
Okay, I'm going to throw open questions to the floor because I'm aware that my own bias towards things digital and data may be getting ahead of us. Who's got a question? Yes?
Actually, I have an observation.
Microphone.
Yeah, I had an observation and two questions, actually. So if you'd indulge me. My observation was that the wording of this session was quite interesting, and I think says a lot about the healthcare community in general, and I don't mean to cast aspersions, but, you know, the circumstances in which we find ourselves in healthcare are what they are. Our ability to engage and lead is in our capability, you know, our ability. So regardless of what health policy looks like in the EU, you know, we as a community in RMD have an ability to make a case, an ability to innovate, and an ability to ask and seek help. And I think that's a really important point, rather than to expect institutions at the EU level to sort of come to our aid. I think we have to encourage them. I had two questions in that context. One was for John Ryan, which was, I felt a little bit as though it was an episode of Scooby-Doo, John, that you were placing little clues to the community about how we may better engage. And I just wanted to pick you up on that a little bit. Assuming the SDGs are a way forward for this community, could we just pick off one? Say, for example, right to work and economic growth, SDG 8, and assuming that our claims as a community around improved access to the workplace, reduced presenteeism, reduced absenteeism, what would you suggest we do as a community to navigate in that context? And my second question was for Marion, which was around inequalities and the life path in the workplace. And I just wondered if maybe you could spend a minute or two just setting out whether the life path between men and women in the workplace is the same, or whether you and your community look at women and men differently.
Okay, thank you for those two questions. John, do you want to go first? Pick a sustainable development goal.
So I think the beauty of the SDGs, is this working? Yeah. Beauty of the SDGs is they're so wide-ranging, but on the other hand, they are closely linked with individual policies. And the Finnish presidency have engaged a process which is going on over the last few months and which will be completed this month, which is a reflection on the concept of wellness or well-being, which I think is very relevant to the SDGs. There was a report prepared for the Finnish presidency by the OECD on the elements which can contribute to well-being. And there are a number of levers which don't automatically spring to your mind when you're discussing well-being. And these include, for instance, the issue of gender equality, so mobilizing and supporting gender equality in society, a very general concept, but also we have strong legislative powers there. So that's an example of where to achieve a state of well-being in the population, you can mobilize things which don't immediately spring to mind, but also educational attainment and support for education, particularly in the more vulnerable parts of society. Social security systems as a means of increasing resilience when employment policies fail. So what I'm saying to you is that the concept of wellness and well-being ties in very strongly with the Sustainable Development Goals and is in fact a term which figures itself in the treaty. So public health figures in the treaty, the internal market is in the treaty, but also the word wellness appears in the treaty, which was a surprise to me when I discovered it. But apparently it's an objective of the European Union to support wellness, or well-being, if you like. So this was a new discovery for me when I found it out, but I think public health clearly has a central role in achieving that goal of wellness, because there's no point in having a job, there's no point in being well educated, there's no point in being gender equal if your health is not there as well. So really it's at the centre, I think, of many of these Sustainable Development Goals and the achievement of economic and social cohesion in the European Union that we do reach these. And I would say, as a last point on this, the Sustainable Development Goals in the European Union are very closely and strictly monitored. So they're monitored at our level, but they're also monitored at the member state level. And in support of what you said, I mean, we're very open to changing our priorities or adding priorities or subtracting priorities. I'm also interested in people telling us where they think we're doing things which are not necessary, because it's nice to add things to the list, but it's also nice sometimes to reflect on whether we need to continue to work in a particular area or not. So we encourage your input on that, and we'd be very happy to have your ideas.
Thank you. Marion, then, how do you define inequalities in the life path of a workplace?
Yes, thank you for that question. Gender indeed is an important topic in our research, and I'm not sure whether I understand the term life path, but I'm going to respond to the gender aspect, and I'm just going to tell you what I want to tell you, and if it's not clear, please come back to me. So, gender indeed is an important a marker of inequality as regard RMDs or SMDs, work-related as MSDs. Why? Different reasons. First, women tend to work more in jobs with less job discretion. So that's one of the it's one of the causal factors. Not very much job discretion. Other elements are also a matter of perception. What is being perceived as a hard job, a very severe job? How do we perceive the work of a nurse in a hospital compared, for example, to the construction industry? It's a matter of perception. Do we see the work of a cleaning lady the same as the work of a cleaning man? That's one part of the perception. Another part of the perception is the fact that women still take a large part of the domestic work in most of the societies. And this is also used by employers to downplay the role of working conditions in the development of MSDs, RMDs in women. I've been there. I've been the director of the Occupational Diseases Office of the Dutch Trade Union Confederation. I've seen many patients, and like hundreds of people with occupational diseases, among which, of course, many in your area. And indeed, there were many more men than women. First of all. So women were not recognized as having an occupational disease. And then in the cases of the women, we often also saw this problem of recognition and the taking on board of the domestic work, the childcare, and not to forget the menopause. So and then so therefore my plea to take the perspective of prevention in work is very important. But another plea I want to make is also the I in the healthcare sector for work as a cause. So because a woman comes to the doctor, says I have pain, she's 52. What does the doctor say? So, I mean, I'm not speaking now at the level of European legislation. It's very much the problem. But the problem is not that difficult. The problem is not that difficult to solve if only we have an eye for these causes, if only we have an eye for also the solutions. Also, for example, at workplace level, so the general solutions for both men and women should be applied to women as well. And solutions at workplace level are really not that difficult. It's the ergonomic structure of the work, but it's also the organization of the work. If you are an RMD patient, and you know that better than I do, you can be very tired, and it might be very helpful if your work is organized in a way that you can start 1 hour later. It's that simple. It's these simple things. And also the same in the room of the doctor that sees a patient and doesn't skip the work of the woman, but asks for it, and then also gives her advice how to deal with it. And there I have a regulatory level in my story as well, because there is no regulation for employers to deal with these issues. It's only the very basic framework directive, and I think what we need from a European perspective is a more comprehensive view on the regulation of the risks that lead to RMDs. A more comprehensive view. This doesn't mean that I'm going to take again the idea that was mentioned this morning of the MSD directive, but a more comprehensive view on the way to regulate this on a European level would be very helpful and could be beneficial. And to finalize, because there was no consensus on this MSD directive back then in the beginning of this century. There was no consensus. Employers didn't want it. But then I hear something here in the room from speakers that we also need to look at benefits of prevention. And if we can put the benefits better forward, then employers might come on board. So that's really important. I went a bit off topic. I realized that. But I told you what I wanted to tell you. So thank you.
Okay. Manuel, you wanted to add?
I just want about inequalities to address also the very important topic of the social inequalities that are related with the risk of poverty and social exclusion, because they are a very decisive factor in the health of people. We know that poor people has low indexes of health, and we must recognize EU is not well succeeded in the fight against poverty. If you see all the panel of indicators of the 2020 strategy for smart, sustainable and inclusive growth, the worst of them is the reducing of poverty. We are not dealing well with that issue. I think that we can have also a good perspective on that, because the new action plan on health will be merged with in a more broader European Social Fund plus process, and I think that it could put the health issues in the link between other social issues, mainly unemployment, fight against poverty strategies. These are very important things. We cannot be very proud of when we have 1 in each 5 European citizens at risk of poverty or social exclusion, and I think that we must address also our attention to those people. I repeat, it's quite demonstrated that they have poor health in comparison with the general population.
Thank you. I see I've got 3 questions in the room. I will take them if you can keep them really, really briefly. I have 2 here and then 1 over to my right.
Yes, I'll be brief. I'm Karine Sipido. I'd like to come to the question that was raised by Neil about mechanisms of decision-making. And I'd like to put it to John Ryan, as he is now going to be co-directing the health research pillar together with DGRTD. And so that gives you an enormous opportunity for leverage in health. So how will you go about for priority, strategy, choices you're going to make? And what about looking for impact and implementation?
Okay, I'm going to collect the 3 questions. There's another one just here.
Yes, thank you very much. My name is Simone Morse. I represent the European Hospital and Healthcare Employers Association. So the name employers has been mentioned various times here, so I'm very delighted that you take us into account. And I'm about now to break a bit the silos, because I like it that we speak here on behalf of the health sector, but also about the social sector, and to put them both together, especially in the healthcare sector. We do touch on both issues. And particularly on, we call it the MSDs, and so musculoskeletal disorders in general. And I wanted to ask you in general, I mean, now, Marianne, you're a little bit biased because, of course, you represent the trade union, but I wanted to give your the attention to the alternative legislation path, which is the negotiations between employers and trade unions in the social dialogue on European level, national level, but also on the company level or on hospital level. So I wanted to ask you, what are the aspects that you would, if you were in a trade union or an employer, etc., what aspects would you like to bring forward in terms of occupational safety and health that needs to be put forward in the next years? So maybe that you make my homework a little bit in a way, but also I want to get your thoughts on as the health community.
Yeah, got the question. So last question over here. Yeah.
Well, thank you. Jacob Hofdijk from the Netherlands. We are facing the situation that formerly we were focused on the disease of patients, but gradually we're shifting to maintaining the health or improving the health of patients. That's a good thing. But on the other hand, patients with diseases got many different diseases, so we move from mono to multidisciplinary problems. And we have also identified that social problems are a very important part of the equation. So we have to take that into account. And as we have discussed in our session, new knowledge has to emerge from this mono to multidisciplinary approach. And the only way to develop this new knowledge is that we speak the same language. And it was addressed during the panel that there was not much discussion about e-health. But I think that we could define a reference for the interoperability of systems, at least in Europe, that we agree on technical, semantical, and social interoperability of systems to provide information at the level of the overarching care plan, which takes into account all the different aspects of that patient and the life goals of that specific patient. So maybe the treaty, which is focused on wellness, can adopt the fact that we need to have agreement on those principles from the IT perspective, because we can't go on moving faxes around from the healthcare systems in trying to coordinate the care of our citizens.
And do you have a specific, I didn't hear a question at the end of that, it's just a comment, but maybe we could get some reaction on it, okay. John, mechanisms of decision making and how will you leverage your future role?
So, yes, it's working. The Horizon Europe program is a 7-year research program. The health budget, as I mentioned, I think this morning, is 7.7 billion euros over those 7 years. So it's a substantial amount of money compared with the health program, which Mr. Pizarro mentioned, which is an annual budget of 65 million euros a year. So 65 million euros a year compared with 1.7 billion euros a year, you can see
It's quite different.
Quite different. So it's important that we get this right. And the fact that the health department of the Commission and the research department have come together to steer the research on health for the next 7 years is a signal. It's a signal that the Commission thinks it's important to link the health systems and the public health departments and the national authorities on health and health systems with the research departments. We're doing this already because we've brought together the authorities from the member states in both of these areas to sit down together and to discuss the priorities. We've published a document which covers the first 4 years of the new programme. It's called a strategic orientation document, and this document is open for your comments. So we had the research and information days, which Fiona mentioned 2 weeks ago, but it's online, it's there. If you think there's something missing, if you think the direction is completely wrong, please tell us. 6,000 people have replied so far. So we read the 6,000 replies. We have 6,000 officials sitting down reading each. Well, DG Research has a lot of officials, but we're putting these ideas together, basically, without joking. We're putting the ideas together. So if you have 5 or 6 ideas in the same area on HIV or on TB or whatever, we'll put those ideas together, we'll group them, and we'll try and summarize them. And the summary will be publicly available. So we're not hiding anything here. We're just regrouping the comments and putting them together. And then we're amending the action plan accordingly. So when the member states have told us they don't agree with the line, the approach we're taking, we've tried to take account of that. When the stakeholders have given us comments, we tried to take account. It's not the Commission deciding, it's the Commission deciding with the member states and with the stakeholders.
Okay, now I am conscious that time is getting tight, so what I'm going to do is I'm going to ask that question on alternative social dialogue, what aspects do you want to see to Marion, and also to Neil, because I'd like to hear the patient, and then perhaps at the end we could get Manuel and Fiona just to comment on interoperability of semantics, or how do we go on with this mono to multidisciplinary approach. And then we can wrap up, because then it's audience interaction time. Okay, so Marion, I'm handing over to you.
Thank you, and thank you very much for your question. It's always nice to meet face to face. Well, your question is quite, I think, into detail, into practice, into what concretely can we do. And of course, the basis of everything is that employers make a risk assessment. They assess the risks of the work. But this is an empty box, as such. I mean, so we need to fill it. And if we speak about RMDs or MSDs, as we call, as we speak about as employers and workers, it's several risks that we have to take into account. And basically, what is called ergonomic risks, but I don't like to speak about ergonomic risks so much because it's a container thing also. I like to speak about several risks that build up this ergonomic risk. First of all, assess the physical risks and the biomechanical risks of the work. But it's not only that. So, and I need to say something before I list up my list of risks. The essential thing is that employers are obliged to prevent any risks as much as possible. And how do they do it? It's to avoid the risks or to manage the risks at the source, but also, very important, to adapt the work to the worker. And there I come to the quote we heard recently: "Adapt of Bernard Shaw, I think. It's adapt the work to the worker instead of adapt the worker to the work." So that's the basic principle. A biomechanical risk, but there's also the way work is organized, the pace and the pressure that is in the work. And so take into account all of these things. And if you make this practical, if you think of a patient that is sensitive to develop an MSD or that already has an MSD, then it's not that difficult. It's to look at the person and to adapt the workplace to that person, both in physical sense and in the sense of organizing the work. And the final thing that I want to say about this is put the worker central. Put and also in the sense of communication, because this is often forgotten. We often think that we know, we have an idea, but it's the worker himself or herself that knows the best what he or she needs.
Okay, in that case, let's hand over then to Neil.
Thank you. So from the thinking about citizen participation, patient involvement, this sort of thing, people like me 30 years ago, let's start there, used to have to knock very hard on the door just to get into the room to have these discussions, actually, on the basis that if you didn't have a seat at the table, you were on the menu. So 20 years ago, we'd moved on, and largely those sorts of elective engagement was beginning to happen, and people were starting to talk about words like patient-centred, putting the patient at the centre of things. I think we spent the last 10 years trying to work out what that means in practice in some quarters. And now suddenly, through especially digital means, patients are doing it for themselves, if you like. So I think one of the big challenges in the next few years is how to see that as an opportunity, not without risks, but see it as an opportunity to harness the patient voice so that we are, in just the way that EULAR as an organisation is constructed, with the three pillars of the patient representatives, the health professionals, and the clinicians and scientists. There you can find a distinctive patient voice, but you can find a unified community voice too. And that's the sort of approach we want to take, not only into health policy and discussions about research, but actually work is going to be our #1 public affairs priority for the next 5 years. So very much looking forward to working with lots of people in this room on that topic. But that's there as a resource. That voice, I think, needs to be supported. We try at EULAR to talk the talk and walk the walk. So when we started, and people like me were saying, patients should be in the room when research priorities are being set, and they should be part of designing research. Suddenly I was needing to be careful what we wished for, because EULAR said, yes, you're absolutely right, how are you going to do that? Do you have the patients ready to supply? So then we had to set about training those patients, and I think that sort of empowerment in practice is something that we need to see more of, so that the policymakers at the European level get the benefit of the richness that comes from listening carefully to the patient voice. We saw with the EUPATI programme, I know some people in the room are EUPATI graduates, where patients were trained through, I think it was through IMI, wasn't it, to be effective contributors on issues like HTA. the more that that sort of support at the institutional and systemic level can be provided to patient representatives in particular, because that's what you asked me, Jennifer, the better it will be for all of us, I think. And it will help to join some of those policy dots as well, whether it's about making transport more accessible, or in our case, with our particular focus going forward, how we can really look at the primary and secondary prevention in gender around work. Because back in the day when I was most severely affected by my RMD, you could say a little that a lot of people with RMDs of working age weren't capable physically of doing that. That's not the case anymore. You know, we've seen such great developments that most people now with RMDs either are working or want to work. Let's exploit that opportunity.
Okay, thank you very much. Okay, Manuel and Fiona, if you keep it very brief, because I'm aware that we're running behind schedule.
I fully agree that we should set rules about interoperability, and I think that perhaps we can find the legal basis on the internal market principles, because however we must leave a door open for innovation or for creativity, and I think that we must combine these two aspects. I fully share the concern of Fiona about the access of people to the innovation, namely in the medical innovation. I think that's a very important issue, and I think that we must struggle to have that all European citizens can have access to comprehensive care and to modern therapies. But I think that we should not be afraid of innovation, because, well, however, if the innovation is the best possibility to all people. We are going to live more and more, I hope, and to live more and more will impose that every one of us will need some kinds of therapies. It's much better can do a biologic treatment for a disease than to take only aspirin, mainly if you suffer from gastric disease.
Okay.
Thanks. Very briefly on interoperability, it's not my specialist subject, but I sit on the board of a civil rights charity in the UK, and this charity tracks EU security, defence, counter-terrorism policy, and does a lot of freedom of information requests on this point. And interestingly enough, we had a discussion earlier this year on interoperability of databases, and it was very interesting to see the amount of times that the word health came up in these documents. So I suspect that there are discussions going on about interoperability of health databases and health records, but not necessarily in the health field, in other fields, and we may well get interoperability, perhaps not for the reasons that we want or for reasons that we're not entirely comfortable with, but it's worth keeping an eye on those discussions.
Okay, thank you very much to all my panellists. I don't want to let you escape just yet, but we will give you a warm round of applause. Thank you for your interventions. So now, if you are looking at your programme, you're going to see a section called Messages to the New Commission. And we're going to gather those with a very interoperable app. So everyone who's got a smartphone, I want your unvarnished reaction to what comes up from this. So if you take out your smartphone, find the browser and type in, just go to www.slido.com, or you can just search for sli.do. It will prompt you to to enter the code for today's event, and that's very easy because it's the one that's been on the screen all day. It's the EULAR Brussels 2019. And I'm doing this along with you so I know how long it takes. Right, join event. And what we've got there are some questions. So if you will see the option for ideas, and you'll see an option for polls. So that is the first active poll. So you can vote. The question is...
What is the
code? Oh, the code, sorry, is EULAR Brussels 2019.
With the...
Yep. The hashtag's already there on the form, so you just type in the letters and the numbers. And then you will come to your home page, where you have an option for ideas, which you can free form. You can enter your ideas there. I'm sure everyone will have a look at them afterwards. And then you have our first poll, which is a very straightforward yes or no poll. Does the EU need an overarching strategy to address chronic diseases, or is the current approach of targeting key risk factors through prevention enough? Everybody vote. 34 votes. There's more than 34 people in this room, I can see that. So we're going to... I feel like I'm going to tell you I'm going to sit here until we reach 65 to make everybody vote. Well, the arbitrary number. Okay, well, let's say I'm going to sit here until we reach 60. Okay, that's...
you are lost.
65.
Well.
Okay. Well, that's... I think even if we sat here until we reach 75, that's not going to change the outcome of that poll. Anyone on the panel surprised by this, or no? No one's at all surprised by that. Okay. Shall we move on then to our next question? The next poll is also a yes or no. Okay, and you can refresh your browser. Is it justified to have a specific EU strategy addressing rheumatic and musculoskeletal conditions, like, for instance, a European cancer strategy? Excuse me, yes or no? Everyone's got the hang of it now. The voting is going up much faster. Okay. So these are the messages to the new Commission. John, you're getting a sneak preview of what people are actually thinking. Are you surprised?
I'm not voting myself, by the way. I'm doing my emails here.
Vouch for that.
I am. I have witnesses. I'm not voting for myself.
Okay. Right. Well, that's gone up to quite a lot of votes on that. So let's go for our last poll, and this is a multiple choice. So, how can EU health policies achieve more impact on social inclusion and employment? And you can select two answers by this. So, by imposing more mandatory rules on member states, by giving more budget to the EU health programme, by giving more budget to the EU's research and innovation programmes, or by involving health professionals and patients more in policy formulation. I now know that we could also, people at home can vote, so it's not just the people in the room, if anyone's watching via the web stream and has entered the code. So. Okay. I think this one's a little bit slower because it takes a little bit more time to work out the preferences between the four and make a choice between two. Okay, has everybody voted who was going to vote? Yes? Okay. Well, I think it's certainly clear that by involving health professionals and patients more in policy formulation is out in front, ahead. But what's interesting is that those other three really aren't, they're all in or around the same. There's not a lot in it. Panelists, would anyone like to comment on that? Fiona, what's your thoughts looking at that?
Definitely a good idea to have more consultation with civil society, I think. Always in favour of giving the EU health programme more budget, but then we do have a conflict of interest on that because we're funded out of the EU health budget, but yeah.
Okay. Yeah?
I'm not surprised about that. I think that we must make more participation if you want to have more success in those kinds of politics that are very complex, that involve a lot of different issues. I think that, of course, budget will be always a problem. There will be never money for everything. So I think we can use money better if we are able to involve people in the decisions about how to use the money.
Okay.
Totally agree with the two speakers, and there's just something I would like to add. By involving health professionals and patients more in policy formulation, health professionals including occupational health professionals, I would say, and patients also in their position as workers.
Okay, Neil.
Yeah, and maybe just to circle back to my opening remarks about the decision, the priority setting process. There was a reference to cancer in one of the questions because it's in the missions letter. I mean, we never talk about other diseases. I mean, who wouldn't deny that cancer should be a priority, obviously? But a priority, and I think there's a pretty overwhelming case if you look at the morbidity and the prevalence and the numbers of people affected in Europe by RMDs, 120 million. I think that makes a strong case for a specific strategy there too. So we look forward to contributing to that over the coming years.
Okay, thank you very much, and thank you for everyone who voted, including anyone who was voting while watching in their home or their office. There's still the ideas section of that Slido. I'm sure the ideas will be collected and help to fuel conversation if you want to write down some new ideas in there. Thank you very much, and thank you again to our panellists.